Hello, my name's Veit Buecklein from LMU Munich, and I'm here to discuss the question, what factors explain inferior survival for EU versus US patients with DLBCL after CAR T-cell therapy? So the starting point for that question was the observation that in real-world evidence analyses, we do see somewhat inferior outcomes for European real-world cohorts for relapsed refractory large B-cell lymphoma after CD19 CAR T-cell therapy. And we asked the question, is that something that holds true when directly comparing outcomes from centers in the European Union and centers in the US? And therefore, we performed an analysis encompassing 374 patients, approximately half from the US, from one center, from Moffitt Cancer Center, and the other half from 5 CAR T-cell treatment centers in Europe. And indeed, when looking at progression-free survival of these patients, outcomes were significantly inferior for the European patients. And also overall survival was significantly impaired compared to the US cohort of patients. So for example, progression-free survival after 12 months was 48% in the US cohort of patients compared to only 26% in Europe. So that's a quite striking difference that we are observing here. Also, when it comes to responses, we do see a significantly reduced percentage of patients that respond to CAR T-cell therapy at all. So CR rates, for example, were 58% as best radiographic response in the US cohort compared to only 38% in the European Union. And the next question that we then asked was, what's the reason for these striking differences? And the short answer is patients that are sent to CAR T-cell therapy in Europe do have an adverse risk profile compared to patients treated in the US. And the second thing is that we do have differences in product choice. So T-cell versus axi-cell in Europe, and this might also influence the outcomes of these patients. One important finding is that toxicity was not significantly different, and also non-relapse mortality was comparable between the US and the EU cohorts of patients. When looking at potential explanations of these adverse risk profiles, we had a look at a wide range of different patient characteristics that might influence the outcomes of CAR T-cell therapy. And for example, we saw that vein-to-vein times were significantly longer in the EU cohort compared to the US. So the time frame between indication for treatment and CAR T-cell transfusion was 66 days on average in the US cohort compared in the European cohort compared to only 50 days in the US cohort. We also found factors like increased or higher levels of LDH, or we found higher levels of ferritin in patients from the European cohorts. And we therefore decided to perform a multivariate analysis to decipher which of these factors have the strongest influence on progression-free survival. We performed this analysis on the whole cohort of patients, so patients from Europe and the US together. And we used a lasso-based model, and we identified non-response to bridging, higher ferritin levels and higher CRP levels as those factors that significantly influence progression-free survival. And when then comparing patients that have been treated in the US and patients that have been treated in the EU, you can see that the distribution of these risk factors is different. So a lasso model describes a coefficient that is associated with any of these variables, and you can then sum up these coefficients per patient and get a patient-specific risk factor. We termed this HR score. And when looking at the HR score from US patients and EU patients, the median in HR score was significantly higher for our European patients. Also, interestingly, the HR score was significantly higher for patients that were treated with tisagenlecleucel compared to axi-cel in our cohort of patients. So the discrepancies that we see in progression-free and overall survival, and also in response, in our understanding, are caused by these differences in risk factors associated with the treatment with CD19 CAR T cells. In addition, we also had a look at the outcomes of patients per product, and identifying by the HR score a high-risk population and a low-risk population in our whole cohort of patients. We could see that tisagenlecleucel was significantly inferior when it comes to efficacy in the low-risk patients, whereas in the high-risk patients, outcomes for both axi-cel and tisagenlecleucel were comparable and were taken together dismal. So to summarize, in our understanding, the significant differences in EU versus US for relapsed refractory DLBCL patients after CD19 CAR T-cell therapy are associated with differences in the risk profile prior to therapy and in differences in product choice.